welcome to And So Much More. My name is Cami Smith, and I am your host. And I am here today with Dr. Lee Jensen, who goes by Lee, so we are going to call you Lee.
Thank you.
She is a neurointerventional radiologist.
Yes.
And there is so much that goes with that. And because I think that sometimes when you hear something like neurointerventional radiology, neurosurgery, so many people think it's over my head, it doesn't impact me, and it does.
Very much so.
There are so many things that I think it's just very important for us to know and be aware of, but then also I just kind of want to hear why you are passionate about it, like what brought you to it. So why don't we start there? Tell us a little bit about yourself and why you got into this.
Okay, so for the listeners, I want to say neurointerventional surgery or neurointerventional radiology is a very long word.
Yeah.
I want people to understand that what the field is basically minimally invasive treatments for neurological diseases.
Yes.
So for years, if you had, for example, an aneurysm, which is a blister in a blood vessel in your brain, and if it were to leak, a surgeon, neurosurgeon, would go in and take your skull off and gently pull your brain back and find the aneurysm and put a clip on it. Now, the vast majority of aneurysms are treated by either going through your wrist artery or your leg artery and floating or guiding a little plastic tube called a catheter up under x-rays, real live x-rays. You put your foot on the pedal and you get the image that you can watch what's going on as you navigate your catheter, which is a plastic tube, up into the site, and block the vessel off from the inside or cover it with something called a flow diverter. And the recovery for the patient is so much better. It's faster.
I imagine.
Right, and it's less invasive.
So that is how you would even define like neurointerventional surgery, correct?
Exactly.
Okay. So, and I think that that's really important to mention because we had a patient on here previously. His name was Ruben Perez. We talked about it briefly. And he had three neurosurgeries. And when you talk about that, I think, our listeners are like, whoa, what? Like you cut his brain open 3 times. And so no, like it was this very minimally invasive procedure that gave him his life back, which is incredible. To just get a little idea. I love how you talked about like you're guiding this to where you need to see to fix what's wrong. So I have all my little questions here. And these are going to be more of just like a guide, but what brought you to Centra?
So I have spent most of my career in academic medicine at the University of Virginia. I did my medical school work, my 2 years of neurology residency, 3 years of radiology residency, 2 years of diagnostic neuroradiology residency, all at MCV in Richmond. So that's where I started. I'm a native Virginian, grew up in Alexandria.
All right.
And then for my interventional neuro training, I went to UCLA in California. It was one of 4 or 5 major medical centers at the time in the country that trained people how to do interventional neuroradiology.
Wow.
And then I came back to the Medical College of Virginia in Richmond for a year, and then an opening happened at UVA, and I took that job.
Okay.
And I took it with one of my trainers from UCLA, a gentleman by the name of Dr. Jacques Dion. So we really grew the practice of interventional neuroradiology in Charlottesville. And after doing that for, 12 years, it became clear that the sort of procedures that we do could also be done in private hospitals. So I had an affiliation with hospitals in Richmond, having spent many years there. And I actually started going over and doing coiling of aneurysms at St. Mary's Hospital in Richmond.
Okay.
And it became so popular, I said, well, let's start a program in the community.
Okay.
And we started doing it full-time at St. Mary's. And that's, in fact, how my current partner, Dr. John Gaughan, came back to Virginia, because he's the one that basically spearheaded that and ran the program.
Wow.
And then we did it at Centra Martha Jefferson in Charlottesville.
Yeah.
So again, all of what we did started out at academic centers, but it really needs to be in the community. Not everybody is close to an academic center.
Yes. Yes.
And you kind of overload the centers. So after we made it work at Martha Jefferson, you actually had, I think, 2 people down here who were doing some similar work, and they left. And so we said, well, let's bring it to Lynchburg too.
I love that.
So that's how it all sort of started.
Yes, what a team.
Yeah.
And we're so fortunate to have both you and Dr. Gon. We've had him on here, and it blows my mind sometimes to see that it's such a different perspective that you have, because you see the benefit that could really be there for our community, whereas our community just, they don't understand it. Sometimes they just move past it, and it's so important for us to stay close to it. Lean into the things that you don't know about.
No, absolutely. Particularly now with, initially most of the interventional neuro was focused on something called hemorrhagic stroke, which is having bleeding into your brain, usually from a ruptured aneurysm. So that's the coiling we were talking about. However, the focus now is actually on ischemic stroke, which is stroke that you have because you've got a blockage. And that blockage can be in your neck, or it can be in your head, or the blockage can come from your heart. So, and this is a clot that forms and picks off and goes downstream. And as you can imagine, as we all know, when anybody says the word stroke, they usually think of this type of stroke, and everybody goes, time is brain, which is absolutely true.
Yes.
Right, and everybody thinks of, I'm hoping, the B fast that you've seen all these posters around. Do you have weakness in the face? That's the F for the fast. Do you have weakness in the arm? Do you have trouble speaking? That's the S. And the time, the T is the time. And the reason we say B fast is because we've added the B and E for balance and eyes, meaning vision, because strokes can occur in the front part of your brain and in the back part of your brain. So the message is out there in the community, if you're having any of these symptoms, to go immediately to the hospital. And that's why the treatments need to be at the hospital immediately.
Yes,
right? We can't just fly everybody into some place like UVA, right? So you need to have them boots on the ground, and you need to treat those patients here. And that's one of the major reasons why Dr. Gon has worked so hard to get the message out to the community that time is brain.
Yes.
Get yourself to the hospital, and we will be there for you.
Yeah, and I'm so thankful that you are. So you've mentioned a few different conditions. Are there any that you haven't already touched on that so neurointerventional radiology or neurosurgery, or that all of this would be a benefit to? What other conditions do you find yourself treating?
So those are the emergency conditions, ruptured aneurysms and acute strokes. But there are plenty of other things that we discover that the patient may be symptomatic but not critically symptomatic, or is found just because they were getting routine workups. So I would say one of the big things would be patients who have carotid artery disease and who have blockages built up in their carotid arteries, which can either be a source for clot formation, which can pick off and go downstream, or can narrow the vessel significantly enough that they're now not getting enough blood flow to their brain, and they're symptomatic from that.
Wow.
So those patients can be done if they need to be treated, and there are various criteria, for whether or not they meet the threshold. Can be treated as sort of outpatients. I mean, they come in, they get the procedure done, and they spend the night, and they go home the next day. And that would be something like carotid stenting. Okay. So a stent is a mesh metallic tube that has radial force. So when you cross the narrowing and you put the stent in, it pops open, and it basically opens up that narrowing. Okay. And then it grows inside into the inner lining of the blood vessel. So that would be something that is offered, but you don't really usually need it on an emergent basis. Sometimes it's part of an acute stroke treatment. You find out the reason the patient is having the stroke right then and there is because the narrowing has completely occluded. Yeah. And so you may have to go ahead and pull that occlusion out, that narrowing or that clot out, go downstream, pull that clot out, and then put a stent down on your way out. But usually it's an outpatient or an elective procedure. Okay. And then the other elective procedure we do a lot of are patients who have had, vascular imaging of their blood vessels in their brain for some reason, and you find an aneurysm. And they don't
Wow.
know they have it,
Yeah.
and it's not caused a problem yet. Many of those patients we can just follow because they're little teeny tiny aneurysms, but some of them are big and ugly. And so you can treat them, again, as an elective patient.
Okay.
So those are some of the major things. Then there's some weird things that we find. Patients who have something called a fistula, which is an abnormal connection between the artery and the vein.
Which was Ruben's story.
Exactly. Sometimes one of the most recent things we're seeing are elderly people who are coming in with sort of declining function, cognitive, thinking function, and they have something called chronic subdural hematomas. And so that's a collection of blood, not in the brain, but on the surface of the brain in this area called the subdural space. And it's slowly but surely getting bigger, and it's kind of pressing on the brain.
Yeah.
And it's just sort of a slow leak. And so one of the things that we can do there is go into the artery that feeds the covering of the brain, called the middle meningeal artery, and block it off. And you can block it off either with these little plastic particles called PVA, or you can use a liquid agent, which is like a glue, like a crazy glue, sort of.
Glue to the brain.
Glue the brain, right. Not quite the brain, but the covering of the brain. And so the idea there is to prevent further leakage, and then the body will reabsorb the blood that's already there.
Okay.
So, and then there's just, sometimes you'll just see what was sort of run-of-the-mill for us. Let's say a patient comes in and they're found to have a tumor called a meningioma, which is a benign tumor growing off of the covering of the brain, but it can press on the brain and cause seizures or headaches or whatever. So those have to come out. The surgeon needs to take them out, but they're pretty bloody tumors. So we can go in and block off the blood supply. So when the surgeon goes in and removes the tumor, there's much less bleeding.
Okay.
And we can do that in the head and neck too. I mean, we basically, cover from here up. So there are some patients that will come in with a bad nosebleed.
Yes.
And normally, the ENT surgeon will put a balloon up and inflate the balloon, and that basically blocks off the bleeding. But sometimes when they deflate the balloon, it starts bleeding again. So we can go in, again, all just through your wrist or your leg, into the blood vessels that supply your nose, nasal cavity, and we can block that off with little particles to stop the bleeding.
Wow.
So there's a whole variety of things that we do. There's some spine work also that we do. Some people will get abnormalities of the blood vessels to the spinal cord called a dural fistula or a spinal cord AVM. We can treat those. But actually, one of the things that I did a lot of study on was something called vertebroplasty, which is a minimally invasive procedure where you put a needle into a patient's spine bone, their vertebral body that's starting to collapse or is partially collapsed from osteoporosis, and fill it with a medical grade cement. It's called cement, but it's really an acrylic to prevent further collapse.
Wow.
And so that was the first procedure for shoring up bone that was soft. You may have heard of kyphoplasty, which is a similar procedure where they put a balloon in, inflate the balloon up, and then put cement in. But that was actually developed in this country at UVA by myself and Dr. Dion, my partner back at the time. Yeah.
This is fascinating.
That's a lot of cool
there's
stuff.
there's so much. So are there any of those conditions that you see more common in this area?
So I don't know if you've ever heard the stroke belt.
No.
So the stroke belt in the United States we're in the upper portion, Central Virginia is in the upper portion of the stroke belt.
Okay.
And it runs down through most of the South, out over into Texas.
Okay.
So you've got, Tennessee, North Carolina, Georgia, Alabama, et cetera, all out. And this is an area of the country where strokes are more prevalent. And a lot of it has to do with just genetics. People who live in that area
That's so interesting.
have a tendency to have high blood pressure, high cholesterol, diabetes.
Wow.
So
not related to like foods or mostly genetics?
So you have that predisposition, right? So if you think about, if you think about families, a lot of high blood pressure runs in families.
Yeah.
Right? If you have a parent or parents that have high blood pressure, you may have it too. And some of it may be due to your diet. I mean, maybe you grew up in a family that had a lot of salt or whatever. But really, these things usually people have a genetic tendency to have these conditions.
Okay.
And when I talk about diabetes, I don't talk about the ones that kids get because their immune system sort of attacks their pancreas. These are people who have a predisposition to have something called insulin resistance in their cells. And again, a lot of that has to do with diet and obesity, but you also have a genetic tendency for it. And same with high cholesterol. So those are the big three that can be controlled if you know you have it.
Okay.
And so, we're here in the stroke belt, and a lot of the patients that we see have the big three.
Okay.
So
interesting.
Yeah, I mean, it's important for you to keep your doctor's appointments.
Yes.
Make sure those things are checked, and it's easy to check. I mean, simple blood test for your glucose and your cholesterol and a blood pressure cuff, right?
Yeah.
And there's so many good medications that you can, take. And you have to make sure you take them because that's the thing. It's good. You got the bottle, you got the pill out of the bottle and take it. But so I think, since we are in Central Virginia, it's important for people listening to this to understand that.
Yeah.
Now, on top of that, there are what we call modifiable risk factors. And the number one is don't smoke.
Okay, can you say that again?
Don't smoke. And I know here we are in Tobacco, Virginia, but don't smoke. Right. And the second one is don't overeat, because obesity clearly has, an effect on all three of those things I just talked about. And the third is get exercise. So, everybody's heard this and they're like, yeah, lady, but
lifestyle choices.
But these are the reasons why people have strokes, people have heart attacks.
Yeah.
Right? And those are the major, killers in the United States. And in terms of stroke, it may not kill you, but you may end up disabled. It's the number one cause of long-term disability in this country.
So what about vaping? Does that fall? Because I know that's becoming increasingly popular. People think it's safer.
No. And I'm not a pulmonary person. I let them talk about fibrosis and all that stuff, how you're basically, killing your lungs. But you don't know what's in it.
Yeah.
Right? You think that the government's out there regulating this stuff. That's not necessarily true. I'm sure the government would love to do it, and I would love for them to do it. But having said that, you don't know what's in it. There's a lot of oils and things like that. And this is true also for marijuana. You don't know what's on it. And, just any drug that somebody gives you, you really don't know what's in it. I don't want to go down that road, except to say that in terms of stroke, there is a condition that we see called reversible cerebral vasoconstrictive syndrome.
Oof.
Long word, but it basically means that the blood vessels in your brain constrict. They get narrower, but it is reversible.
Okay.
But it's reversible if you stop doing what you're doing, right?
Yes.
And sometimes we actually have to treat it. There's ways that we can do that by going up and injecting a drug that relaxes the muscle in the blood vessel. But you have to realize the vessels have little muscle in it. And if you irritate it, it can clamp down. If it clamps down, it can't carry blood to the brain.
Yeah.
And so people will have stroke-like symptoms or a frank stroke. Okay. And so we see that with people who are smoking marijuana and cocaine users, and it's another vasoconstrictive. Something else we need to think about too is there are things that predispose you to clotting. Okay, so there are some genetic conditions that you may get from your parent that you don't know you have until you start getting weird clots, something called factor V Leiden, and antiphospholipid antibodies, all these different things. But and often, again, because there's the genetic component, you might know somebody who in the family had a clotting disorder. But one of the big things is birth control pills. Hormones in pregnancy increase your risk for clotting.
Well, that's not fair.
Yeah, it kind of sometimes stinks to be a woman. But anyway.
Okay.
But it's something just to think about. And I'm not saying don't use birth control, because if you don't want to have kids, use birth control. But just recognize that one of the things that we will see is patients coming in with clots in their brain veins.
Oh my.
as opposed to not necessarily it being on the arterial side.
Mm-hmm.
And so those patients present a little bit differently. They often come in with a really severe headache, which makes people think of aneurysms, but from our standpoint as physicians, we need to remember, yeah, it can also be in your veins too.
Yeah.
And we also saw this increase during COVID.
Really?
Yes.
And any idea on what may have?
The virus itself.
Oh, wow.
Yeah, there's actually been studies looking at the clots that we pull out of people with the virus being in it. And I can tell you just anecdotally, some of the clots that I pulled out, they're very different from the other types of standard clot we'll pull out. They're very gummy, very sticky. They almost act like a cork.
Oh, my gosh.
So, these are things that people don't hear about,
Yeah.
but,
Yeah.
have come out through what we've learned and what we've seen clinically going through COVID. It's like, why are we all of a sudden seeing more people with what we call venous sinus thrombosis?
Yeah.
So anyway, so those are just some of the more weird things
Yeah.
that we might
So
see.
interesting.
Yeah, it's pretty interesting.
and I hope that our listeners, I mean, if I were listening to this, you would see me writing all of this down because there's so much to know and understand, and that awareness can just really save your life, save someone's life close to you, which makes me wonder, like, how much interaction do you have with patients to share this information?
So when we see people in clinic, and we see them, ourselves as the physician and also with our fabulous nurse practitioner, Genevieve Harway, all of us kind of, really dig into your medical history and look to see what those risk factors are that you have. And then we go over the things that you shouldn't be doing that are bad for your health and things that are good for your health and why. And I think one of the biggest messages that I always send out is everybody is afraid of having something wrong with them.
Yeah.
Okay? And everybody would like to think, oh, my leg's not working, I will sleep it off.
Constantly.
Okay?
Yeah.
The problem is many of the things that we can do for you as an acute stroke is time sensitive. And if you wait too long, you will no longer be able to get the treatment because you've waited too long. So when we look at sort of the history of treatment of stroke, the first probably major breakthrough was in 1995 with a trial that looked at giving patients who met certain criteria that were having strokes just a drug, an IV drug. That's the TPA trial that I think everybody has heard of at some point in time. So that's the whole time is brain thing.
Yes.
Right, and you have to be in the hospital and been evaluated and had certain things done within 3 hours of onset.
Oh, goodness.
Right. So if you're let grandma sleep it off, when grandma finally gets to the hospital, it may be too late.
There's so much that can't be done.
So from our standpoint, from an interventional standpoint, depending upon what type of stroke you're having, and we treat the large vessel occlusions, it's the clot that either comes off your neck or comes from your heart and lodges in one of the big vessels in your brain, either your middle cerebral artery or your internal carotid artery, your basilar artery. We can go in and pull the clot out. Our time window is a little more extended. But again, it's one of those things where you're more likely to do well if I pulled the clot out at hour 4 than if I pulled the clot out at hour 7.
Wow.
And we too have criteria based upon imaging that you get beforehand, CT angiogram, CT perfusion, to determine whether or not you're a candidate.
Okay.
So the major message I would say to the people listening is there are so many ways that we can treat stroke and we can make your outcome better. In fact, you can go back to normal, but if you don't get to us in time, it will be too late.
Yes.
And you will not be a candidate for any of the therapies that we have.
Oh my goodness. And that I think is scarier to think about than just, oh, there might be something wrong with me, is not getting the help you need when there is something wrong with you. And so, just being aware at the time, act on what's happening. And like, I think you said this earlier, forgive me if you didn't, but have communication with your primary care doctor. I think that that's where the relationship becomes so valuable, because then they can start to see patterns, or they can start to see an abnormality in your pattern and say, this might be something we need to lean into. And so we're always, whenever we talk about, the things that happen or occur within our health system, so much of it traces back to that primary care relationship. And it's just so important. And I think a lot of us put it off in the same way that we sleep off a headache, or we sleep off pain in our leg, or, we tend to take care of the people around us before we take care of ourselves. And so lean into your primary care appointments, and then listen to your body and do what is right. Head in, get the help you need. We talked a little bit before we started about headaches, and I love what you shared, because headaches are one of those things. It's actually Headache Awareness Month, Brain Awareness Month, Migraine Awareness Month. And so as we want to shine a light on, what do you do if you have this reoccurring migraine? You mentioned the thunderclap headache. In what way do you pay attention to those to get ahead of maybe it being a leading factor to stroke?
So one of the things about ischemic stroke, the ones with the blockages, is it doesn't necessarily hurt. You can have a headache when you're having an ischemic stroke.
Yeah.
For most of the strokes that we see that have severe headache, it's really, there's been a bleed, and that bleed is either into the fluid that bathes the brain, called the subarachnoid space, and blood is very irritating to the subarachnoid space, and that's why people get this sudden onset of severe headache.
Wow.
They try to touch their chin to their chest, and they can't because their neck is stiff.
Yes.
Or they have a headache that is progressive, but maybe not thunderclap. That could be part of a ischemic stroke syndrome, or fluid filling in the subdural space, as I was talking about. I would say any headache that is new or unusual, that concerns you, you should, for lack of a better thing to do, go to the ED. I mean, the easiest thing that can happen when you're at the ED is they'll just do a CT scan of your head and show that there's no blood, and then look at you from the standpoint of, could you be having an ischemic stroke? I mean, if your face is drooping, or you're dragging your leg or whatever,
signs.
Right? Exactly. And then if not, migraines often will run in families. Migraines often start when patients are younger rather than older, and so that's when they can get directed into one of our neurologists who specializes in headache, or to their often family practice primary care individuals will be sort of the first line of working that headache up for maybe something else, and then sending them on to somebody who's a specialist. And your point about your primary care physician and seeing them is spot on, but right now in medicine it can be hard to find a primary care physician. So there are other resources, and one of them is just the health clinics. There are just,
talk to me about the health clinics.
Well, I don't know how many health clinics you have here in Central Virginia. I'm a little more familiar with the ones that are up in the Charlottesville area.
Yeah.
But I mean, there's various things that you can do. For example, one easy thing is just to go to your CVS or your local pharmacy. A lot of them will have put your arm into the cuff, and it'll check your blood pressure right there. Okay. And if it's super, super high, then most people end up going to the ED because they need to get that down.
Yes.
Right? And I'm not trying to send everybody to the emergency department. Please,
yes.
That's not the
Please don't.
That's not the message here necessarily, but clearly if your blood pressure is like 200 over 110, you are having a potential hypertensive crisis. Okay. So one of the things that I encourage my patients who have high blood pressure is get a cuff and check your blood pressure yourself every day. There's a lot of inexpensive cuffs that are out there. I bet you there are programs that can get you a cuff inexpensively. Okay. And check your blood pressure yourself. That's one thing that you can do just to manage your blood pressure. Yeah. But in terms of the health clinics around here, I would see what the county and the state have, where you could just go in and get your blood pressure checked, or get your finger pricked and see what your glucose is.
I mean, because I only ever have that done when I'm at my doctor's office, or if I go into urgent care, or
Well, there's some, there are health fairs that have been down here.
Yes, we do have some great health fairs.
There was one here, I think, back in April that Dr. Ellicott or Dr. Santillan, one of my partners at the time, actually went and spoke at. So there are resources out there.
We'll go ahead and put some resources, some future health clinics, health fairs, and things that are happening in the description, just so that can be available as a resource.
I think that's a good idea.
But yeah, this is just so much good information. I thank you so much for your time. We have hit all that I have kind of laid out, but I did want to ask you, is there anything else that we didn't mention that you wanted to share?
I think the important thing is I want people to be aware of their body and not be afraid to ask questions. And of course the issue is, who do you ask that question to? So the first thing is to have somebody that you trust and that you can go to and ask those questions. And then don't be afraid to get treated either. There's so much fear around what's going to happen. And quite frankly, I think people, when I deal with them, they are so much more relieved when they know actually what's going on with their body. And there is something that can be done about it. And there's a team of people that are watching out for them. And so I have a lot of patients, Dr. Gaughan's a lot of patients that, they have little aneurysms. And we watch and we see them every year. We look forward to it. We look forward to seeing them. They get their imaging study. It's unchanged. Everybody just feels so much more relieved. And that's the best thing that you can do for yourself is to have peace of mind that I'm doing the best for me.
Yeah, peace of mind goes a long way.
Yes, it does.
Well, thank you so much, Lee. I appreciate it. And thank you all for joining us on And So Much More. Check out the description. We'll put some resources in there for you.
Excellent.